Medical Foundation and our Mountain View office, and she's an incredible resource for us in neurogastroenterology and motility, trained and practiced with Bill Snape. Many of you know Dr. Snape from CPMC. So Katerina is going to take on the next topic for us and review some of the developments at DDW in this field. Thanks, Katerina. And then we'll generally have time for questions, just like we did at the end. If we can use the microphones, I know it's a little effort to get up there, but I think it'll help everyone else hear the questions a little bit better. Thanks. All right, Katerina. Should show up.
Advancing.
That's the point, but I think you can just do this too.
Eric, thank you very much for this nice introduction, and I want to thank organizers for inviting me to speak here. Today, I would like to go over the most interesting abstracts which were presented at DDW this year. So we'll touch up on each portion of gastrointestinal system. We will start with the esophagus, talk a little about treatment of reflux, about some motility abnormalities. We'll look into cannabis effect on gastrointestinal symptoms and high-resolution manometry findings. We will look at gastroparesis. We will not forget about abdominal bloating as well. The first study which I would like to go over is the prospective multi-center registry of lower esophageal sphincter stimulation for GERD. The data is coming from Europe and Latin America. Safety and efficacy of electrical stimulation of lower esophageal sphincter using the endostem LAS stimulation system has been demonstrated in clinical trials for up to 4 years. The authors presented prospective international multicenter web-based registry of patients with GERD symptoms treated with that modality. The data was collected at baseline and at routine follow-up up to 5 years. They recorded demographics, adverse events, GERD symptoms, GERD-related quality of life for heartburn, as well as for regurgitation scores, use of proton pump inhibitors, and pH data. pH data was only collected when available. Data is available for 223 patients from 16 sites in Europe and Latin America. Mean age was 50 years of age, and 59% of patients were males. We will take a look at the GERD quality of life, heartburn, and regurgitation data on the next two tables, and review pH data for those patients for whom it's available. In this table, you see the scores for GERD quality of life, heartburn, presented at 12 months, 24 months, and 36 months. And it's very exciting to see that there's statistically significant improvement pre and post-implant. Improvement not only persisted, but you can hypothesize it got better over time for 3 years. The same was for regurgitation. You see it's 1 year, 2 year, and 3 year data, pre and post-implant. And we also see that patients definitely had improvement in health-related quality of life regurgitation scores, and the difference persisted over a period of 3 years. When they looked at the pH data, it did improve as well. The pH improved from 8 pre-implant and for some patients and 6.2 pre-implant to near normal values, 4.5 at 12 months, 3 and 6 months respectively. The device implantation resulted in 8 adverse events. 7 patients were affected, and only 4 patients had device explanted as a result of the adverse side effects. The side effects included gastroparetic symptoms, lead dislodgement, palpitations, pain, and dysphagia. No deaths were reported. In conclusion, endostim for lower esophageal sphincter is effective in treating reflux in routine clinical practice. You can argue, but overall the side effects and adverse events are acceptable. Unfortunately, we don't have this available in the United States yet. The studies and trials are still ongoing. It's not approved by FDA. If patients are interested, you need to look up which centers are involved in this trial. What will be more interesting is to know whether patients who undergo this modality still need PPIs, and if this can be used alone or need to be used in combination with other treatments we have available for GERD. But overall, it's very promising surgery. Next, we will talk about treatment of hypercontractile esophageal disorders with Botox. This is result of randomized placebo-controlled trial. Botox have been shown to be efficient for the treatment of achalasia, and only some studies showed a possible effect on the esophageal spasm or nutcracker esophagus. The goal of this randomized study was to assess the efficacy of Botox versus placebo in patients who had symptoms associated with esophageal spasm or jackhammer esophagus. The diagnosis was made with high-resolution manometry according to Chicago 3 classification. Patients were included if they had dysphagia or chest pain of long duration for at least 6 months, and if they had classic criteria for esophageal spasm or jackhammer esophagus on high-resolution manometry. They were excluded if they had history of esophagogastric surgery, malignancy, large hiatal hernia, or severe esophagitis. They were randomized to placebo or Botox injection, and Botox was injected in several points at the level of cardia and in the esophageal wall. Total 100 international units was injected. The endoscopic intervention was blinded to the patient and physician involved in the follow-up. At 3 months follow-up, patient had repeat dysphagia score and repeat high-resolution manometry. At that point, at 3 months, if there were no better, they could choose another Botox injection, whether second for some or first for those who received placebo. And the last clinical follow-up and manometric follow-up occurred at 6 months after initial procedure. 23 patients were included. 13 of them were women. Mean age was 60 years of age. 13 patients were in the Botox group and 10 was in the control group. The mean dysphagia score was similar in both groups. The initial manometric diagnosis were 12 had jackhammer esophagus. Majority of them, 9 of them, were in the Botox group. There was 9 esophageal spasms and 2 atypical cases. The dysphagia score significantly improved at 3 months without any difference between Botox or placebo. And the clinical improvement seems to be more noticeable for esophageal spasm patient than for jackhammer esophagus in dysphagia scores alone. More interestingly, most of the cases resolved to normal manometry or ineffective esophageal motility at 3 months, regardless of what treatment administered. And there was no reported complications to endoscopic procedures. Well, personally, I was a little disappointed knowing the Botox efficacy was not proven. The study is still small. You could think if a large number of patients used, results could be different. Using different quantity of Botox, 200 international units may make a difference. Their technique was slightly different from what used in the United States. They did inject some of Botox in the cardia, some in the esophageal wall. You would say if 100 international units are used, maybe only 50 of them would go in actual esophageal wall, and maybe that was not enough for jackhammer esophagus. So definitely more studies are needed. But the most important point of this study is, number one, the symptoms do improve over time even without treatment, and the fact that manometric findings change over time at 3 months, even without Botox treatment, raising important question of natural history of spasm and jackhammer esophagus. It doesn't mean that I will send all my patients for repeat manometry every 3 to 6 months, but for those who definitely not doing better and heading toward POEM or more definitive surgical intervention, repeat manometry may not be out of question. Next study will cover cannabis use on gastrointestinal symptomatology, endoscopic and high-resolution manometry findings, a retrospective case control study. Recreational cannabis use is increasing with legalization in many states, and medical marijuana is prescribed for a variety of upper gastrointestinal complaints. Animal studies suggest that cannabis can reduce transient lower esophageal sphincter relaxation. It can change reflux, vomiting. In 2016, cannabinoid hyperemesis syndrome was added to Rome criteria for functional gastrointestinal disorders. Human studies have conflicting results on visceral sensation and abdominal pain. So the authors decided to look retrospectively at their data of patients who took cannabis. They looked on all the available data between 2006 to 2017. They had 2,300 patients. 772 of them were used cannabis. Almost 1,600 were controls. The cases consisted of those with documented cannabis use, and non-cannabis users served as randomly selected controls. They checked presenting complaint, demographics, frequency, and duration of cannabis use. They looked at endoscopic and manometry and impedance findings. The most common complaint in cannabis users was abdominal pain, and most common complaint in non-cannabis users was heartburn. Those who used marijuana were likely to be male, African American. They had tendency to be younger, with mean age 49 versus 59 in controls. 64% of them endorsed daily use, and abdominal pain was prevalent in 25% of them, heartburn in 15%, and nausea with vomiting in 7% of cannabis users. Cannabis users also had statistically significant higher prevalence of esophagitis at 8%, non-erosive gastritis at 30%, and erosive gastritis at 14% compared to controls. The high-resolution impedance manometry showed intraesophageal stasis in 65% of patients on cannabis, and hypertensive lower esophageal sphincter in 27% of them versus 8% in non-users. And even so, they saw abnormal manometry findings in cannabis users. They could not diagnose it based on Chicago classification. Overall, abdominal pain was the most common complaint in cannabis users. The hypertensive lower esophageal sphincter with intraesophageal stasis was definitely predominant abnormality. The authors hypothesized that it can explain increased heartburn and vomiting in those patients. And this study bringing awareness that cannabis may not be a benign substance, which now many of our patients may be using. It may exacerbate or initiate a variety of gastrointestinal symptoms. And we definitely need future studies to understand effect of cannabis not only on symptoms, but on gastrointestinal motility and perception in general. Switching gears, moving down to the stomach. The next two studies will be related to gastroparesis. The current study was part of the gastroparesis consortium data. They looked at gastric emptying changes over time in patients with gastroparesis. The importance of this study, because will help our patients with gastroparesis to answer question, how will they do year, 2, or 3 years down the road? Will their symptoms or gastric emptying changes remain the same, get worse, or get better? Gastric emptying tests are used to diagnose gastroparesis, but not usually or rarely obtained in follow-up. And aim of the study is to determine if changes in gastric emptying occur over time in gastroparesis, determine characteristics of gastroparesis patients whose gastric emptying changes over time, and determine symptom changes over 48 weeks in gastroparesis patients who have changes in gastric emptying. The methods are: patients with symptoms of gastroparesis were enrolled in gastroparesis registries for 6 years. Patient had idiopathic or diabetic gastroparesis, and they had gastric emptying at enrollment and at follow-up at 48 weeks. The gastric emptying scintigraphy was performed with standard protocol. They assessed symptom severity with PAGI-SIM questionnaire. All patients received standard of care during follow-up, and they defined worsening or improvement in gastric emptying as changes of 12% up or down in gastric emptying retention number. They used logistic regression models to compare improved retention to no improvement. On those graphs, you see idiopathic and diabetic patients. X-axis showing percent retention at enrollment, and Y-axis showing percent retention at 48 weeks. They are divided by etiology: idiopathic, diabetic, or total. As we can see, there's difference between patients with idiopathic or diabetic gastroparesis, how their gastric emptying changes over time. Results: 142 patients with gastroparesis were included. 36 of them had diabetic and 106 had idiopathic gastroparesis. The gastroparesis cardinal symptom index decreased from 2.8 at enrollment to 2.5, statistically significant difference. Gastric retention at 4 hours also decreased from 30% to 21% at follow-up. To remind you, we do diagnose gastroparesis if a patient had 4-hour gastric retention over 10%. Overall, 22% of patients had worsening, 42% had no change, and 43% of patients had improvement in gastric emptying. 36% of patients normalized their gastric emptying at 48 weeks, which is over a third of patients. And gastric emptying worsened in patients with diabetic gastroparesis mostly, compared to patients with idiopathic gastroparesis. Which factors were associated with worsening or improving gastric emptying? Worsened gastric emptying was associated with greater duration of symptoms, lower quality of life physical component scores, and if patients had gastric electrical stimulator. Improved gastric emptying at 48 weeks was associated with increased gastric retention at enrollment, higher symptoms of reflux, initial use of narcotics, which is most important modifiable factor, but it was not related to acute onset of symptoms or initial infectious prodrome. Improved gastric emptying at 48 weeks was associated with symptom improvement, symptoms of nausea and upper abdominal discomfort, and not surprisingly, patients gain weight. Independent enrollment characteristics with improved gastric emptying was younger age, chronic progressive symptoms, use of narcotics, increased CRP level, and lower depression scores. In conclusion, gastric emptying can change over time. Most patients will improve or remain the same. And improved gastric emptying was associated with initial increased gastric retention, opioids use, less depression, more severe GERD, and elevated CRP. And symptoms improved with improvement in gastric emptying was decreased nausea, improvement in pain scores, and weight gain. So next study is also related to patients with gastroparesis, but looking more at patients with nausea and vomiting. When we see those patients in clinical practice and we start evaluation, we do have a couple modalities. We have in our armamentarium the gastric emptying test with nuclear scintigraphy testing, which we discussed in the previous study. And we also can use smart pill. This is the tool which will allow us assess not only gastric emptying through the gastric transit, also to take a look at small bowel and colon transit times. In a way, it allows to assess generalized gut transit. This study is coming from the same centers, which are tertiary referral centers involved in gastroparesis consortium. They looked at symptom and quality of life outcomes in patients with suspected gastroparesis in relation to delays in gastric emptying and generalized gut transit. So as we know, gastric scintigraphy and wireless motility capsule tests facilitate diagnosis of gastroparesis and may influence clinical decisions. The impact of gastric emptying testing on longitudinal symptom outcomes and quality of life is unknown. The two hypotheses were delayed gastric emptying as assessed as either modality is associated with worse gastroparesis symptom and quality of life outcomes, and delayed generalized transit on wireless motility capsule also relates to worse symptoms and impaired quality of life at 3 and 6 months follow-up. 167 patients with more than 2 gastroparesis symptoms such as nausea, vomiting, early satiety, bloating or fullness of over 12-week duration at 10 centers underwent concurrent gastric emptying study and wireless motility capsule. Based on the results, the management plans were devised to change drug and diet therapy and order further diagnostic tests. The gastroparesis symptoms were quantified by gastroparesis cardinal symptom index and PAGI-SIM scores between 0 and 5. Quality of life was measured by PAGI quality of life surveys, again ranging between 0 and 5, 0 being poor, 5 excellent, at the baseline, at 3 months and 6 month follow-up. The delay in gastric emptying and delay in generalized gut transit were defined as gastric emptying delay if over 10% were retained in the stomach at 4 hours. By wireless motility capsule if capsule stayed in the stomach for over 5 hours. And delayed generalized transit if it was present in 2 or more gut regions, such as stomach, small bowel, or colon. The results. The symptom scores decreased from 2.6 to 2.2 to 2.0 at 0, 3, and 6 months follow-up, so there was definite symptom improvement. Quality of life increased also exponentially from 2.6 to 3.2 at baseline 3 and 6 months follow-up. The gastric emptying tests were delayed by gastric emptying scintigraphy in 25% of patients and wireless motility capsule at 35% of patients. Delayed gastric emptying by other modality was associated with worse symptom outcomes at 3 and 6 months, and we'll review those results in the table. When we look at these symptoms, only postprandial fullness subscores were clearly related to emptying delays, and if patients had normal emptying, their fullness scores severity were better. Some quality of life measures were worse with delayed gastric emptying at 6 months, and they met their initial hypothesis by proving that delayed generalized transit was associated with worse symptom outcomes. This table was structured in the following way. You see the transit parameters when the transit emptying by gastric emptying test, gastric emptying by motility capsule, and generalized transit by wireless motility capsule. You see 3 months follow-up and 6 months follow-up. Each group of patients were divided in 2 groups by doing better or worse. So you see gastric emptying divided on patients with cardinal symptom index score improving or worsening. Same for gastric emptying by wireless motility capsule and by generalized transit by wireless motility capsule. Some patients do improve at 3 months follow-up and 6 months follow-up, even if they have delay in gastric emptying. 33 to 40% of patients do improve. But those patients who don't do well, they definitely more prevalent in delayed transit group, and they do differ statistically significantly from patients with normal transit. And most remarkable statistically significant difference is present if patients not only had delay of gastric emptying, but also had delay in entire gut transit. The patients had different quality of life. Again, not surprisingly, those with delayed gastric emptying had worse quality of life compared to those with the same symptoms of nausea, vomiting, bloating, early satiety, but they had normal transit time. And the difference was statistically significant and mostly significant at 6 months follow-up. So in conclusion, patients with gastroparesis symptoms reported improved symptoms and quality of life at 3 and 6 months after transit testing. Documentation of delayed gastric emptying by either modality associated with worse symptom and quality of life. And generalized transit delay was also associated with worse symptom outcomes, illustrating potential advantage of measuring transit in all gut regions in patients with suspected gastroparesis. And this study emphasizing important point, even so our patients present with what we consider upper gastrointestinal symptoms, which is nausea, vomiting, early satiety, fullness, we do need to look at the entire gut transit because that probably playing a role, as proven by this study, in their overall symptoms and their overall quality of life. The last study I'll go over is related to patients with gas and bloating, which we see in our general practice all the time. This study is coming from Italy, and the study is looking at patients with gas and bloating and outlet dysfunction. Bloating and abdominal distension are common and bothersome complaints in patients with functional gastrointestinal disorders. Studies have provided evidence of impaired bowel gaseous content as relevant etiology in functional bloating. And aim of this study was to evaluate relationship between defecation pattern, symptoms, and abdominal girth measures in patients with functional gastrointestinal disorders who came to gastroenterology office for bloating as a main complaint. This is prospective, multi-center study on 76 patients of Italian heritage who had severe bloating, identified by visual analog scale, 100 millimeter scale, as the score over 24. Bloating had to be their primary complaint, and visible abdominal distension was not necessary for enrollment. Patients were also grouped based on Rome-3 criteria with functional gastrointestinal disorders. All patients were prescribed 2 weeks of dietary advice and complete lactose abstinence. Belt around the abdomen was assessed for abdominal girth. During run-in, all patients completed a daily log, which included bloating score, Bristol stool scale, and stool frequency. At randomization visit, all patients filled a questionnaire on subjective adequate relief of bloating, further bloating visual analog scale, and they measure their abdominal girth with a belt. They did the measurement 2 hours after meal. All patients reported no relief of bloating at the end of run-in, underwent a balloon expulsion test with Foley catheter. The balloon expulsion test was scored as a successful or unsuccessful if it was not expelled within 2 minutes. So 76 patients completed the run-in. The functional GI comorbidities were 6 patients had IBS-D, 6 IBS mixed, 30 were with IBS constipation, 9 had IBS unidentified, 6 had functional constipation, 3 functional dyspepsia, and 16 functional bloating. Significant negative correlation was found between subjective relief of bloating and bloating visual analog scale and abdominal girth changes. 69% of patients reported no improvement or worse symptoms after 2 weeks of dietary advice. Among those who did not respond, majority, 68% of them, failed the balloon expulsion test. The multiple regression analysis showed the balloon expulsion test was dependent variable and was related to bloating severity. And they did not find any relationship between failed balloon expulsion test and functional gastrointestinal disorder diagnosis. So whether the patient had IBS-D, IBS-C, or functional constipation, that was irrelevant in terms of that finding. In conclusion, in this prospective multi-center trial of modified diet, there was subjective benefit in only 30% of patients consulting for severe bloating. In the non-responder population, outlet dysfunction was prevalent and correlated with bloating perception, supporting role of biofeedback. I would say this study brings important point again when we see patients with bloating. In addition to working on a diet, looking for SIBO, looking at gastrointestinal motility, abnormalities, or working on visceral perception, we need to assess now, proven by the study, pelvic floor function. I don't think I will send patients to pelvic floor physical therapy from the start, but definitely asking them if they have to strain excessively when they defecate, if they have sensation of incomplete evacuation. That will be important. Rectal exam can provide initial assessment for pelvic floor dyssynergy, and then you can either send them for anorectal manometry. If you have balloon expulsion test in the office available, this is a very useful tool, and not to forget about it. Thank you very much. Any questions? I got it from internet. I Googled the sunrise as depicting the future of neurogastroenterology and motility. There's more on the horizon. Thank you. No questions? Oh. So, yes, cannabis hyperemesis syndrome definitely has the same features of cyclic vomiting syndrome. And now with legalization of marijuana, I think we'll see it more and more often, so it should not be overlooked. Patients do not usually disclose their cannabis use, so a high level of awareness needs to be taken. In my practice, my patients fill up a questionnaire, which is regular PAGI-SIM, but I also include a graph of smoking, alcohol, and cannabis. Especially when I first time see patients, I don't need to ask, I look, and then I'll bring it up. Sometimes I ask proactively if they don't mark anything. In terms of how they ingest it, whether they smoke or they ingest it in the oral form, I did not see a big difference. The symptoms are the same, and presentation is the same. You just need to find this acceptable individual, like in whom it start doing those things. How to deal with this? It's a tough one. Unless they stop using it, there is no other way to treat it.
I offer them up a choice. I mean, you can continue your habit
Exactly.
It would slow down.
It's a highly,
Less.
highly addictive substance.
Yeah.
Yes?
Have you studied any patients with severe hyperscoliosis where the stomach may be higher than the esophagus?
Hmm.
Have you studied anybody like that? I've seen one patient who continues to lose weight because he cannot eat a meal.
I did not have anybody with bad scoliosis. With bad paresophageal hernias, we do see patients in whom stomach definitely goes out of the position. With the scoliosis, unless stomach goes in the chest, if it's just distorted like this in abdominal cavity, I did not see those.
Because rather than standing like this, he stands like this.
Right.
So how does, he's got difficulty with swallowing to get it into the stomach and cannot even eat a reasonable sized meal because it fills up very quickly because of the anatomy.
This is a tough situation. Those patients might have difficulties tolerating solid meal. The liquids and meal modification, the postural position definitely can play a role. If they have a functional obstruction due to position, you can kind of look on upper GI which position would be the most beneficial for them when they eat, and a good radiologist can help with those simple, just positional modifications. And filling up, they will need to, I don't think I would ever use prokinetics, or maybe I could try gently, all situational, patient dependent, but mainly do everything possible to prevent aspiration. If the delay in transit happens in the esophagus, ask them not to lay down after they eat. And I bet the liquids will be emptying easier and going through, and soft foods will be going through, and they'll just need to take their time eating and be aware of it. No breakthrough. No breakthrough. So this is the two studies which came from the largest group on gastroparesis. So, and I presented.
Katerina, thank you for a wonderful review. A quick question. What's your practice on patients asking for medical marijuana prescription for functional nausea? And they swear that, yeah, I tried my Frank stuff, it helps me, can you give me a prescription? It's cheaper to get through prescription than buy, and you see all the data for One syndrome kind of stuff happening. How do you counsel them? And
Why don't you use the microphone?
Can we get them to
So-
compulsorily use the microphone?
The question,
Cannot hear.
so the question was, when I see a patient who is asking for medical marijuana for treatment of nausea, what do I say? I honestly, going back to the studies on animals, the studies which I usually quote to my patients, the studies on rats, did show that cannabis slows down stomach, small bowel in dose-dependent fashion. I see a lot of patients with cannabis hyperemesis syndrome, and I try to avoid giving medical marijuana for nausea, and I never advise marijuana in general. Overall, when I see my patients taking marijuana and I see them for first consult, I try gently introduce the topic saying, listen, this is what we'll do, but the possibility of your symptoms could be that you're using cannabis. So there are selected patients with cancer. There are patients with painful conditions who do need medical cannabis. But if patient has functional gastrointestinal disorder, such as nausea, I try not to, I steer away from it. Thank you.